Good afternoon, everyone, and welcome to the National End-of-Life Care Intelligence Network's webinar to introduce the Atlas of Variation for End-of-Life Care. My name is Kerry Archer-Dutton, and I work within the End-of-Life Care Intelligence Network. Giving the presentation today, we have Nicola Botel, Analytical Programme Manager, and Andy Pring, Principal Analyst. We also have Siobhan Shepherd, who will be assisting myself. Please can I ask that you stay on mute, and if you'd like to ask a question, please do so via the instant messaging on Skype or by emailing neolcin@phe.gov.uk. The webinar is going to be split into three sections: the background, the introducing the Atlas, and then other resources available. We'll be pausing to take questions at the end of each section. I will now pass you over to Nikki. Thank you, Nikki.
Thank you, Kerry, and welcome all to this afternoon's webinar. I'm going to start off, as Kerry said, talking about why it's important to have an end-of-life care atlas. And in this section, I'll look at why we are interested in variation in Public Health England, why we produce atlases of variation. I'll then move on to why end-of-life care is important and why we're producing an atlas of variation in end-of-life care, and finish off looking at what other end-of-life care atlases are currently available globally. So variation, what does it mean? If I just now have a few brief words on why we should care about variation. We have a National Health Service and Public Health Service, so we would hope that wherever anyone lives, they should have the same chance of good health, a long life, and indeed a good death. We know that this is not true, and therefore the atlases explore the contribution of health services and public health interventions to these inequalities in outcomes. Population-based need is heavily influenced by demography, especially the age and socio-demographic makeup of the population. Most conditions increase in incidence and prevalence with age and are higher in more deprived populations. The ethnic makeup of the population may also influence the distribution of the conditions. Importantly, these demographic factors affect not only need, but also, together with travelling times, may affect access. There are patient factors, for example, health literacy, economic availability, and doctor factors like lack of clear protocols or adherence to these protocols, all of which may affect end-of-life care and advanced care planning. So, variation. The concept of variation is usually classified into two types, and as shown on slide 6, that is warranted and unwarranted variation. So what is warranted variation? This is described as differences that reflect patient-centred care and clinical responsiveness based on the assessed need for the population served. Moving on to unwarranted variation. This can be best defined as variation in the utilisation of healthcare services that cannot be explained by variation in patient illness or patient preferences. This variation is indeed unacceptable. It wastes resources and it is the hallmark of poor quality and lower value healthcare. Investigating the causes, i.e. over-provision, inappropriate provision, offers us the opportunity to eliminate this type of activity and improve care for all. So moving on now to the next section on slide 7. On this slide, you can see many atlases that we have produced with colleagues, and the End-of-Life Care Atlas will become part of this series of atlases. Indeed, the first NHS Atlas of Variation in Healthcare was published in 2010 as a compendium covering a wide range of indicators. This has had 2 updates since, and alongside this compendium, we have also produced specialist atlases for example, on diabetes and liver disease. And the End of Life Care Atlas will join these specialised atlases. So, for those of you who are not familiar with our Atlases of Variation, on slide 8, I am showing you what a typical page for an indicator looks like. This will be available in PDF format, and as you can see, there is a wealth of information provided on 2, sometimes 3 pages for each indicator. You will get for each indicator 3 images. That's a map highlighting the variation, a column chart and a box plot. And indeed, Andy in the next talk will explain these figures in more detail. We also, alongside the data, importantly provide other vital information to drive change. So we provide a context for each indicator, why we've chosen that indicator, some text describing the magnitude of variation in England for the indicator, and importantly, we provide some options for action and resources to use when addressing issues at a local level. So, we've touched on the Atlas and the Atlases of Variation in Public Health England. In slide 9, I now turn to the important issue of why an end-of-life care atlas. Well, as you can clearly see on this slide, while over 500,000 deaths per year happen in England, that's almost equivalent to the population of Somerset. We therefore feel it's so important to shed light on the provision of end-of-life care in varied geographical contexts and to help assess the gap between end-of-life care need and provision in England. So on slide 10, it's also important for us to note important demographic changes that are occurring with our ageing population in England. Ageing in the UK population is projected to continue. Indeed, by 2035, it is projected that the median age will have risen to over 42 years, an increase in 2.5 years in the quarter century after 2010. In terms of increases in the number and proportion of older people in the UK population, the percentage of persons aged 65 and over increased from 15% in 1985 to 17% in 2010, an increase in 1.7 million people. And by 2035, it is projected that those aged 65 and over will account for 23% of the total population. Okay, moving on to slide 11. It's also important to note that deaths in England are also projected to increase over the next 2 decades. As you can see in this slide, this means it is increasingly important to shed light on variation in access to good end-of-life care in England. Much policy has driven end-of-life care service provision and configuration in England over the last decade. And as you can see on slide 12, there have been many policy documents that have driven this change. So reflecting on this increased drive to drive and improve end-of-life care in England through policy, we can see on slide 13 that both home deaths and care home deaths have increased over the last decade. Home deaths having changed from 19% to 23%, and care home deaths from 16% to 23%. And in turn, we have also observed a reduction in hospital deaths for the same period. So policy has been driving change in England. But as you can see in slide 14, what factors are associated with place of death and how can we continue to improve quality of care? This slide has an awful lot of information on it, but essentially it provides a summary of work undertaken by Gomez and Higginson fairly recently. And it highlights the complexity of factors influencing place of death. These include factors relating to type of illness, demographic factors, healthcare provision, social support, and indeed family support. And we will be looking at some of these factors as part of our first Atlas of End-of-Life Care. Finally, on slide 15, you can see we are not the first provider of an Atlas of Variation in end-of-life care. Indeed, around the world, there has been growing interest in mapping levels of palliative care provision. Some of this has led to the production of many atlases. These include a European atlas, which presented the development of specialist palliative care in 2013. More recently, Scotland also produced an atlas on palliative care, but our atlas will be the first that is produced for England. Thank you. Are there any questions, Kerry?
Okay, thank you, Kerry. Yes, I'm Andy Pring. I'm one of the analysts who's putting together the End-of-Life Care Atlas at Public Health England. I've got about 20 minutes during which I'm going to briefly run through the 30 or so measures we are preparing for the Atlas. Secondly, I aim to describe and explain the way in the Atlas, explain the way the data will be presented within the Atlas, give you a brief glimpse of some of the draft graphics we've already produced and which will be published in the Atlas in a few months' time. I'm now on slide 18. The Atlas will be arranged in a number of sections. After an introduction, the measures are ordered into 5 domains, 4 of which are loosely grouped together by place of care. That's the home, hospital, care home or hospice. The other domain has more contextual measures in it, and we've loosely entitled that demand. So the demand domain is headed up by data from the Office of National Statistics, which describes the projections of the number of deaths up to 2030. Then there are 2 measures. Oh, sorry, I'm momentarily distracted. Okay, so that after the projections figures, there are 2 measures describing what percentage of deaths might be described as elderly, both 75 and over or 85 years and older. We hear much about the aging living population. It's now regularly in the news. But as a consequence of this trend, there's an increasing proportion of deaths occurring at an older age, often of people living with multiple comorbidities. Also in this domain, we present the key performance indicator, death in usual place of residence, which has been produced by ONS and published by Public Health England for a number of years now. On slide 20 now, I'm looking at the measures we're going to present describing the percentage of deaths according to their cause of death. And we've chosen these groups to be representative of people for whom advanced care planning and end-of-life care may be particularly relevant, and not necessarily to describe all deaths. In particular, I'd like you to notice that for chronic obstructive pulmonary disease and dementia, we've chosen to include in the count not only deaths with the condition as an underlying cause of death, but also those where the condition is recorded as a contributory cause of death. So, looking at slide 21, and we're looking at the hospital domain. There is evidence that the best end-of-life care can result in fewer hospital admissions and a reduced percentage of deaths that occur in hospital. So, in the hospital domain, we start off with a percentage of deaths that occur in hospital, followed by 4 measures that we've developed using hospital episode statistics. That is, the percentage of deaths, percentage of people seen in a hospital in the last 90 days before they died, the percentage of deaths in hospital that occur after admission of 8 days or longer, the mean time spent in hospital during that final 90 days, and the percentage of people having 3 or more emergency admissions in their last 90 days. In previous publications, we've looked at last year of life as an end-of-life care period, but on reflection and discussion with stakeholders and others, we felt this was too long, and we've chosen to focus these calculated measures on the final 90 days. The hospital setting is one of the few where we will be able to present quality of care metrics, and we will include key outcomes from the National Care of the Dying in Hospital audit, details of which we're still finalising with them. Finally, in this domain, we are including the delayed transfers of care statistics. On slide 22, for many, a person's own home will be the place where they spend most of their time in their last months of life. And in this domain, we start by looking at the percentage of deaths that actually occur at home. Unfortunately, it's proved difficult to get data that describes quality of end-of-life care at home or within primary care, but we have included some figures produced in the Quality Outcomes Framework, QOF, which report the number of patients on a GP practice list entered onto their palliative care register as I suppose, a proxy of the active consideration of GPs that some of their patients are near end of life. Social care is increasingly in the news, but we've not included any particular social care metrics, mainly because we found it impossible to separate out figures just for people near the end of their life from the many with ongoing chronic conditions. But we have included the contextually important data from the census of the percentage of people declaring themselves to be carers and the percentage of adults who are 65 years old or older and living on their own. Slide 23. Care homes, both residential and nursing homes, are major providers of care for people nearing or at the end of their life. Again, quality of care metrics is hard to come by. And in this domain, we've included percentage of deaths that occur in a care home, the size of care home population, that's from census data, some care quality commission data describing the local care home bed capacity. And we finish this section with two measures that we've derived from using death certificate data. Firstly, the percentage of deaths in care homes that are temporary residents, by which we mean people whose recorded residential address is not a care home, and yet they die in a care home. And lastly, looking at all the people with a home address of a care home, what proportion die in a care home. Moving on to 24, the specialist palliative care provided in hospices and by hospices working in the community are rightly highly valued, but again, unfortunately, it's proved near impossible to source data that can be used in an atlas to describe variations in care in this setting. What we are left with in this section is the percentage of deaths that occur in a hospice, and of those deaths, the percentage who died from cancer. I do recognise that this is likely to significantly underestimate the role of hospices and does not really describe the quality of care they provide. And I very much hope that better data might be available in the future. I'm going to walk through the data produced for a couple of these measures and how it's presented in the atlas. This is a mock-up of what the atlas will look like. Nicky's already shown a similar page. It comprises a map, a column chart, box and whisker chart, and some narrative information. And I'm going to explain how to read some of these graphical elements, and in doing so, I'll use the death in usual place of residence measure. So we're looking at slide 26, which is a column chart. The aim of the column chart is to illustrate the range and distribution of values of the measure across the different areas, which are CCGs in this case, in comparison to the value for England as a whole. England's represented by the horizontal yellow line. Each CCG, in effect, is represented by quite a thin, narrow column. Whether any particular value can be described as different from that for England as a whole is indicated by the colour of each column. CCGs with values significantly different or higher than England are coloured by the darker shades, and those that are significantly lower than England are indicated by the lighter shades. There are 2 darker and 2 lighter shades, which indicates the levels of confidence, 95% and 99.8%, the most dark and most light shades being the highest level of confidence. That the recorded value really does indicate a difference from England. It takes just a little thought to understand the colours and why these colours mix. Many of you may be more familiar with the presentation in quintiles, where geographic areas are grouped strictly by rank, and a similar chart would be coloured in distinct blocks. The colour mixing is a consequence of statistical confidence for each of these values, depending on the size of the sample, and the fact that CCGs themselves vary in size, and so consequently have different levels of confidence intervals associated with their figures. So CCGs, where the measure is based on a relatively small sample, have values with lower confidence and consequently wider confidence intervals. This can mean that even if such an area has an apparently high value in absolute terms, its wider confidence interval may include that for England, and the CCG cannot be described confidently as statistically significant. The consequence of this is the colour mixing effect. The other point to bear in mind is that the England value is used as a reference, but it's not meant to be the right or optimum value. We intend to make no implication of that at all, but rather the England value is used as a reference around which we can describe variation. So this chart, death in usual place of residence, we seem to vary from just short of 60% to a little below 30%. That's what we might call a twofold variation, with a central group of CCGs not significantly different from England, but at each end of the chart, a sizable group of CCGs that have a value significantly higher or significantly lower than England. Now we understand, or perhaps I confused you about the colours, we can understand the same key on the maps. And we'll look at chart slide 27, and here we see some clear geographic patterns with a significantly higher, that's the darker values, in the southwest, East Anglia and parts of the north and south coast. Striking how many CCGs with significantly low values are in London. Yeah, if we look at 28, we can see the box and whisker chart, which the Atlas uses to describe trends in values and their variation across the country. For each year, which is along the horizontal axis, the death in usual place of residence values for CCGs are summarised by the box and whisker plot. The central line, indicated in red at the moment, indicates the median value, i.e. that's the middle ranked CCG. Now if we go along to 29, I've highlighted the interquartile range. That's the height of the box, which is the values represented by the middle 50% of CCGs. The whiskers, highlighted on slide 30, the extent of the whiskers describe the range from the highest to the lowest values. In 31, we can see that I've highlighted these little ticks halfway up the whiskers. Again, these indicate the range represented from the 5th to the 95th percentile. I.e. that's the range where the top 10 and bottom 10 CCGs are removed, and it shows where 90% of CCGs lie. We're on 32 now, and I've highlighted this little column at the end of the table at the bottom of the slide, and that describes the significance of any trends, the trends in the median and the trends in the ranges represented by the box and the whiskers. So for this measure, the chart shows that the percentage of death in usual place of residence is rising. The rise is across the board, by which I mean that the maximum and minimum are rising at about the same rate as the median, and the extent of the variation as described by the height of the box and the extent of the whiskers is not really getting any narrower, not at least not to the extent that the effect is statistically significant. Okay, well, I'm going to go on and talk about some of these hospital indicators. And 33, here's the column chart for the percentage of people seen in hospital during their last 90 days. The range is from 56% to 75%. And as ever, there's a block of CCGs in the middle who are not different in England. And at either end of the chart, there are CCGs that are either significantly higher or lower. Slide 34 shows a map, and here I find this map quite striking, with most of the CCGs, which are significantly lower than England, being to the west of a line from Shropshire to Sussex, together with parts of the northwest and East Anglia. The significantly high values seem to be in the northeast, a stripe across from Merseyside to Hull and parts of the Midlands and London. There is, at least superficially, quite a lot of similarity between the maps for death and usual place of residence and the people seen in hospital. Page 35, slide 35, puts these two maps together. And if you look, you can see that many of the areas with high deaths in usual place of residence, that's showing as dark colours on the left, have low values of people admitted to hospital, showing as lighter shades on the right. I.e., to turn this round a bit, areas where death at home or a care home are common are those areas having the lowest percentage of people admitted to hospital in the last 3 months before they die. Okay, now quickly to finish, slide 36 looks at the percentage of deaths with 3 or more emergency admissions in the last 90 days of life. This column chart illustrates quite a spread from 3% right up to 12%, with many CCGs in the middle, not significantly different from England. But again, at either end, there's a sizable chunk of CCGs who are different. The map for this measure on slide 37 seems to highlight London, together with the line, possibly a hint of the line from Manchester to Leeds and parts of the northeast, as having significantly high values, while the southwest are low. The trends in 38, we can see not only an increasing trend in the median over recent years. So back in 2007, the median was something like 5%, up to over 6% in more recent years. But also, all the measures of variation are increasing. Have a look at that table at the bottom, and the right-hand column says significant. So there's quite a lot going on this chart. At this stage, I can do little more than hypothesize for the reasons behind these trends. I'm not even sure whether it's a good or a bad thing. I wonder about the possibility of people nearing the end of their life coming into hospital, but in line with current thinking, efforts are made to discharge them home or to a care home as soon as possible, and perhaps, consequently, where they may in the past have stayed in hospital for many weeks, they are discharged earlier and sicker, with the consequence of increased risk of readmission. And perhaps that's what we're seeing here, with the rising percentage of people with 3 or more admissions in their last 90 days. Okay, I've come to the end of my short allotment of time, and please forgive me, I could not give you any more than a brief glimpse of what will be published. But I do hope this atlas will be of interest and useful to all those who seek to provide the best care they can to the people at the most vulnerable times of their lives. Okay, I'll pass it back to Kerry.
Thank you very much, Andy. So we've got time for some questions. Who will do our third part? Thank you, Nikki.
Thank you, Kerry, and thank you, Andy. So as Andy said, we'll be publishing our atlas shortly. Indeed, the plan is to publish in the second quarter of 2017. However, many of you may be asking, what can we use now to inform local planning and service configuration, and indeed use alongside the atlas once it's published. So what I plan to do now is to provide brief whistle-stop tour of many of the data resources we have produced in Public Health England that we hope that you can use to support yourselves in community commissioning and planning end-of-life care services. So on slide 41, I'm showing you the two main platforms where you can find these resources. On the left, you can see the Data and Knowledge Gateway, and the link for that is provided at the bottom of the slide. Then on the right, our other platform for locating our data tools is Fingertips, and there you can see the web page for that. Both of these web portals are organised to provide easy access to the appropriate tools and are thematically organised. So most of our tools are on Fingertips, and as I've listed here a few of those that are readily available at the moment. I've highlighted some of the most relevant tools to end-of-life care commissioning and planning in red on slide 42. But I do stress you should start with our end-of-life care profiles when investigating local data issues. But alongside our end-of-life care profiles, you can use many other resources. We have a number of disease-specific profiles, for example, on cancer services, cardiovascular disease, diabetes and liver disease. Or you can indeed look at our social care profiles to look at social care and informed planning locally. Or indeed you can look at specific populations, and our older people's health and well-being profile tool enables you to look at some of the healthcare needs locally for your elderly population. But you will also find a wealth of information on end-of-life care and indeed its evidence-based reports, data and tools on our National End-of-Life Care Intelligence website. The link for that is provided at the bottom of slide 43. And as I mentioned earlier, and we're on slide 44 now, our main data tool produced by the National End-of-Life Care Intelligence Network is the End-of-Life Care Profiles. And there's a wealth of data available for investigation on these profiles. With time, we will add new indicators as and when they become available, because we want to make sure that that data is shared as speedily as possible with our stakeholders, yourselves. And indeed, mirroring that, our profiles will, with time, include some of the indicators and the new indicators we are currently preparing for our Atlas on end-of-life care. And we will keep you informed when we do start to populate the profiles with those new indicators. But what do we currently have available on the end-of-life care profiles? Well, we're now on slide 45, and before I'm on this slide, I've listed 3 of our 7 domains where we thematically list the indicators for our atlases. I won't go into the detail of what is in each one. You can take this away and read this in your own time, because we haven't got that much time today. But the domains are, as listed here, place of death, death in usual place of residence, underlying cause of death. And then moving on to slide 46 are the final 4 domains in the end-of-life care profiles are our mortality domain, dementia domain, and another domain that has a number of additional contextual indicators, and finally our most recent domain, which is our care home domain, which looks at end of life in the care home setting. moving on to slide 47. This is just a very, for those that are not familiar with fingertips and our end-of-life care profiles, this is just really a very quick way to get you started. So as you can see, the top ribbon is where you select the domain, the thematic area that you're interested in, to look at the indicators that are available. Then moving down to the second ribbon, this is where you select your view. So how do you want to look at the data? Do you want to look at charts, trends, maps, etc.? Once you've then selected your view, you move down to the third ribbon, and that is where you will see and select your geography you're interested in, and indeed the benchmarks you're interested in. So for example, as I'm based in Bristol today, I would select the Southwest and Bristol Local Authority, for example, and benchmark. I could benchmark against England or the Southwest. Okay, so that's how you get your views and you select your data. Moving on to slide 48, I'm just highlighting for those not familiar with fingertips. These are the sort of views you get when you select your data and you select your view. So you can see on the top left, the compare area view. On the top right, we have our trends view. And the bottom right, we have the map view. And importantly, within fingertips, we have the functionality where you can download these images as JPEGs, and we welcome you use them in local slide presentations or indeed reports. That's how it's designed for yourselves to use. So that's fingertips and the end-of-life care profiles. There are many other resources, so I'm going to move swiftly on, as you can see in slide 49, to another resource that's available. And this is called Local Health. On Local Health, there are over 80 indicators available, and you can download the data into maps or in profiles. But importantly, what Local Health enables you to do is to look at variation at lower geography. So you can look at variation within your own local area. It provides data at middle super output area or ward area. And what I've listed for you on slide 50 is what data is available to support end-of-life care, because that's what we're talking about today. And here, and you, again, as I mentioned earlier, I'd rather you take this away and look at the detail behind it. But there is a wealth of information to support end-of-life care commissioning in this invaluable tool. There's demographic data, so you can look at your population and your elderly population locally, and there's data on disease and poor health, life expectancy, cause of death, and important emergency admission data. So that's what's available. What can you get? Well, on slide 51, I've given you an example of an output from Local Health, and this is looking and focusing at the percentage of population age 85 years and over living in London. Again, with quintiles, as Andy explained with the other maps, the darker the colour, the higher the percentage living in that geography. And you can see quite clearly that London is a much younger population than England. Moving on to slide 52, this is another tool you can use to explore variation within your local area. And importantly, there is a lot of information within the general practice profiles to support end-of-life care commissioning and service planning. This includes local demography data and information from the Quality Outcome Framework, QOF data. So there's much there to interrogate in the general practice profiles. And again, I've listed those indicators within the specific domains. So to the left you have the domains that are available in GP practice profiles, and I've listed and highlighted some of the ones that lend themselves to end-of-life care planning that you may want to go and have a look at your own local data. And importantly, I'll highlight one at the end, which is the one Andrew referred to in his talk, which is already currently available to you in this tool, which is the QOF prevalence for those on the palliative care register. So what do you see when you look at the GP practice profiles? You use it systematically, as I showed you with the end-of-life care profiles. This is also in fingertips, so the same principles work. But what do you get here? And here I've used the example of Haringey and those GP practices, and what you'll see in is the output for those GP practices in Haringey, where in Haringey CCG, where the registered population are currently on the palliative care register. And you can see the variation immediately in this chart across GP practices in Haringey. And I did note a question has come through around using spend data in our profiles. And I'm thrilled to release, and I would encourage all to use this with the Atlas. Last week we published a new health economics tool to support local commissioning for end-of-life care. The link to that is provided for you at the bottom of slide 55. But alongside this new tool, we have also produced a review of the available evidence-based supporting health economics and end-of-life care. And there's also a guide to support you and get you going when and if you feel you want to use this tool in the future. In Public Health England, we also have an important tool that we fondly refer to as SPOT, the Spend and Outcome tool. And this is shown for you on slide 56. This is you can use this in interactive spreadsheet format, or if you prefer, you can download the PDF for your local area where summaries are provided. Importantly, linking spend in your local area with relevant outcome measures linked to that spend. And this you can use at CCG level or local authority level, dependent on your need. And on slide 57, I have listed for you the indicators that are available for you currently in SPOT. There aren't any specifically on end-of-life care. There is no spend measure within CCG or local authority returns. But there is information, importantly, on older people and social care, and I've listed some related outcome measures for you as well, but you could link to that spend locally and understand what's happening in your context. So, for example, you could look at the spend locally on older people and social care and link it to the percentage of 65s receiving at home 91 days after discharge. That's just one example, but there are many other combinations you may want to explore. And this is the sort of output on slide 58 that you would get. You can see on slide 58 how the Excel interactive tool looks. There's a wealth of data here. It's really worth exploring. And this is one example of the outputs that you can get for your local area. I haven't got time to fully explain that today. I'm conscious of time. But there is a video accompanying this tool at the same landing site that I have provided the link for you. So if you are interested, I'd encourage you to use that video to get yourself started. Importantly, Andy and I have shared with you today many tools and data around end-of-life care and to support end-of-life care commissioning. But what we would like to reiterate, and I am on slide 59, is that informed decision making locally is the best outcomes you get is if you combine multiple sources of intelligence. So best practice, systematic reviews, qualitative research, guidance, alongside our tools, and talking to local actors will really inform decision making. So we're rounding up now, and on slide 60, importantly, where will you find our end-of-life care Atlas of Variation when it's published in a few months' time? Well, I've provided you the link here, and this link on slide 60 is basically where all the atlases are currently published, including in the future our end-of-life care atlas, and there you will get a PDF and a data spreadsheet, and we will let you all know by email as you've registered for this webinar when it actually goes live, and keep you all informed. And importantly, alongside that, we will be populating our end-of-life care profiles. The link is provided for you again on slide 61. And we will populate that with indicators that we will be using in the static PDF and in the spreadsheet, because we recognise many of you will want to go away and look at your own local data to explore more closely what that means for you locally. Okay, so I'd like to thank you all for listening today and remind you all, as you can see here, to sign up if you're not familiar with our National End-of-Life Care Intelligence Network e-alerts. We produce these monthly, and in those monthly updates we put anything that we've recently released, put on our end-of-life care profiles, or any reports we've published in that month. So it's a good way to keep in touch with future developments with the National End-of-Life Care Intelligence Network. So at that point, I should be quiet and say, are there any questions?